Dear colleagues, my name is Hermann Beere and I'm the director of the Center for Reproductive Medicine and Andrology of the University Hospital in Halle, Germany. And in the next minutes, I will provide a lecture on gonadotropin therapy in clinical practice. And I will talk about evidence-based applications in the management of male infertility. The content of the following presentation is the result of an effort to ensure the greatest possible objectivity and independence. The presentation is solely for educational purposes of physicians and is not intended to promote the use of any products. I have no conflicts of interest related to the content of the following presentation. In the first lecture by Professor Simoni, you heard about the hormonal regulation of male infertility. And in this graphic, you can see the testes producing the sperm for fertility and producing testosterone in the Leydig cells. And Professor Simoni showed you that this function of the testes is controlled by the two gonadotropins, FSH and LH, and these gonadotropins are stimulated by GnRH coming from the hypothalamus. And when we talk about male infertility, it is quite important to distinguish between the primary hypogonadism and other forms. And primary hypogonadism, and this includes infertility and low testosterone, primary hypogonadism has the origin within the testes, so problems within the testes. And Professor Simoni in the first lecture showed some data how we might hyperstimulate testicular function by gonadotropin treatment. And in the last lecture by Professor Estes, we will hear about different forms of male infertility where gonadotropin treatment might be useful, also in patients before testicular sperm extraction for ICSI therapy. But in this talk, I will mainly talk about the secondary hypogonadism. Secondary hypogonadism means that the reason for the hypogonadism, this means low testicular function, has secondary reasons, and they are in the hypothalamus or other brain structures or the pituitary gland. And in these cases, you can have very effective hormonal treatment of male infertility. But before we start this treatment, we have to do the appropriate diagnostics. And for example, when a patient comes with azoospermia or oligoasthenoteratospermia, so very low sperm values, we first look then at the endocrine values. For example, here, especially the follicle stimulating hormone, the FSH. And if the FSH is low, this is typical for a secondary hypogonadism. And these patients will have small, smooth testes because these testes are not stimulated. And there are other forms, and you will hear some more about these forms in the other lectures. But in those patients with secondary hypogonadism, we have to do additional tests. That's very important. We have to look at the LH and testosterone levels to see whether there's also a decreased testosterone, and this is due to a low LH. We have to look at the prolactin levels because we have to exclude a pituitary tumor, a prolactinoma. Some patients we have to do some combined pituitary gland stimulation tests. And very important is the magnetic resonance tomography of the cellular regions to exclude any tumor in this area. And we will do olfactory tests. And if there is pathological findings, and this is clear for secondary hypergonadism, low LH, low FSH, and low testosterone, and in most cases azoospermia, we can identify the diagnosis. It can be congenital hypogonadotrophic hypogonadism or idiopathic hypogonadotrophic hypogonadism, Kalman syndrome. These have additional olfactory disturbances, and it can be insufficiency or tumor of the pituitary gland. And if we identify these patients, then we can do the proper treatment of the male infertility. And one way would be to give pulsatile GnRH by subcutaneous pump at a dose of 5 to 20 micrograms GnRH every 2 hours. And this is possible in patients where the GnRH is decreased, for example, because of hypothalamic or other brain reasons. And then you can treat with GnRH, and this exogenous GnRH will stimulate testicular function and fertility. You also can give LH, especially in those patients who have low LH levels, and the medication we normally use is HCG these times because HCG has a longer half-life and will stimulate intratesticular testosterone. And the typical dose is twice 1,000 units per week, for example, Monday and Friday. And depending on the patient and the testosterone levels, you can increase or even decrease the dose of HCG. And if there is a low FSH level, you can treat with FSH, and today this can be given by subcutaneous injections. And the typical dose is 3 times 150 units per week. This means, for example, on Monday, Wednesday, and Friday. Or in previous time, we gave HMG, which has FSH and LH activity. And in most patients, you will give a combination of HCG and FSH. Because if there's a pituitary problem, in most cases there's low LH and FSH, but there are also some patients who have still some low but still sufficient levels of FSH, and in these maybe HCG is sufficient. And also some patients might have some residual LH activity enough to stimulate intratesticular testosterone, and then you might give only FSH. But in most patients with pituitary problems and also with hypothalamic problems, you give a combination of these two drugs. So how does it work? And here I show you some slides that were provided to me by Professor Paulsen from Seattle, a very well-known andrologist who passed away several years ago. And as you don't do any testicular biopsies in these patients, normally these are special slides where you can see what is the case in these patients before you give gonadotropin treatment. So you can see here the seminiferous tubules, and you will not see any elongated spermatids, no real full spermatogenesis. And on the right side in the patient, after treatment with gonadotrophins, you can see full spermatogenesis, even with elongating spermatids and sperm in the tubules. So this is a clear sign for successful treatment in this patient who had a Kalman syndrome, so a low GnRH secretion. Again, Today, we will not do it, this testicular biopsy, for diagnostic purposes. Now I would like to talk about the efficacy of gonadotropin treatment of patients with secondary hypogonadism. And I will show you some data we collected several years ago, especially when I was working with Evo Nieschlag in Münster, and these are consecutive patients. And you can see here there are two groups, group 1 and group 2. In group 1, these are patients who have congenital form of hypogonadotrophic hypogonadism or Kalman syndrome. And group 2 are patients with pituitary problems. And if we start here with group 2, these were 21 treatment cycles. These patients were treated with HCG and at that time HMG, 30 cycles of treatment, 21 patients. And the average age was 34 years. And group 1 with congenital hypogonadotrophic hypogonism, as I showed you before, you can treat those patients with pulsatile GnRH or directly again with HCG and HMG. And here you can see they're similar regarding age. But most important in this slide is, please look at those patients who had a cryptorchidism, a mal-descended testis. And only 1 of 21 patients had a mal-descended testis in the group with pituitary problems, but 3 out of 6 patients in group 1A or 8 from 18 in group 1B had cryptorchidism. And this is typical. And this might be one reason for a lower efficacy of gonadotropin treatment. If you go on and now look at the spermatogenesis, and all these patients in the two groups, all these patients had azoospermia. And now you can see in how many patients we were able to induce spermatogenesis. And you can see that in this group 1A with GnRH treatment, group 1B with HCG-HMG treatment, we were able to induce spermatogenesis in 86 or 90%. So quite good efficacy. But in the group 2 with a pituitary problem, we were able to induce spermatogenesis in all patients. And what is very important from the practical standpoint is that this takes time. And here are the months of therapy until we detected sperm. Here it can be 4, 6, here in the pituitary group again 4 months. And you can see here the range of treatment. Sometimes it can last longer than 1 year. And especially if we look at the pregnancy rate, this is even more pronounced. If you look at the month of therapy, and here we look the month of therapy until conception of the female partner, until the pregnancy was achieved. And the pregnancy rate shown here in this column, you can see a very high pregnancy rate, especially in the patients treated with pituitary problems treated with HCG, HMG. The pregnancy rate was 81%, very good result. And in those patients with a hypothalamic problem, it was a little bit lower, but still a quite good success. On the other hand, again, this took quite long, 6.5, 8, 10 months, and the wide range as shown here. Again, this is very important. Don't stop treatment prematurely. This can take sometimes several years. So how can we, when we treat those patients, how can we get an idea how efficient this treatment is? And especially from my clinical practice, it is very clear that the increase of testicular volume is a very important value. And in this slide, you can see the total testicular volume before therapy and the total testicular volume after 6 to 12 months of therapy on the y-axis. And you can see in the three groups here that there was a clear increase of testicular volume. And this happens if you do the testicular sonography even before you can detect sperm in the ejaculate. So I would recommend, if you treat those patients, always do testicular volume measurement, especially, or the best by ultrasonography, so you can have very accurate numbers for testicular volume. And in the next slide, this is a very important slide regarding optimal treatment of these patients. And here on the y-axis, you can see now the sperm concentration. And on the x-axis, you can see the duration of therapy in months. And here I displayed the sperm concentration in these treated hypogonadotrophic hypogonadism patient up to the point when the female partner conceived. And you can see, especially in this group with pituitary problems, here the triangles treated with HCG, HMG, sometimes the increase of sperm concentration can be seen after 1 month, 2 or 3 months. Please note that this is a logarithmic scale. But in other patients, especially those with hypothalamic problems, this might take longer. And again, if we look at the sperm concentration up to the time point when the female partner conceived. So here, for example, it's no surprise that the female partner conceived. This patient had a sperm concentration after a few months of higher than 100 millions per ml. But for example, this patient here, we treated this patient for 45 months. He achieved a pregnancy in the female partner without assisted reproduction with very low sperm count, sperm concentration here lower than 1 million. And this is very important. In many patients, you are not able to achieve a sperm concentration in the normal range, even after prolonged treatment. But you should continue, and many of these patients not achieving normal sperm concentration will, in the end, induce a pregnancy. And this is very important for practical reasons. And what's the reason for this? The reason is that in most of those patients with hypogonadotrophic hypogonadism, and here you can see a diagram indicating the male reproductive function. If the patient has hypogonadotrophic hypogonadism, no sperm, so actually the function is absent. And but most of the female partners of the man have optimal female reproductive function. And if you can induce spermatogenesis to normal levels, this couple will achieve the desired pregnancy within a few months. But in some patients, you can only stimulate spermatogenesis to a level that's still in the subnormal range, but also this couple will achieve the pregnancy because most of the female partners have optimal reproductive functions. So what are the predictive factors for treatment success? And this is again important for your clinical practice. You can see here 4 factors, and these are important factors predicting successful infertility treatment. First is a history of normal puberty or pubertal arrest. So if a patient had some puberty, for example, when he later develops a pituitary tumor, this is a predictive factor for successful treatment. If the patient had no history of cryptorchidism, this is a predictive factor for successful treatment. And this might be the reason, as I indicated before, that patients with hypogonadotrophic hypogonadism due to hypothalamic reasons might have lower treatment success. If the patient has a higher baseline testicular volume, again, predictive factor for successful treatment. As I indicated, testicular volume is a very, very important parameter. And if the patient has a higher baseline serum levels of inhibin B, it's also a good predictive factor for successful treatment. So in your practice, you can use these 4 factors to talk with a couple and how what can be expected from this treatment. And I showed you now our data some time ago, but in the meantime there are other analyses from other groups, and I just would like to show you here a recent meta-analysis on the efficacy of gonadotropin treatment in hypogonadotrophic hypogonadism, published a few weeks ago. And this is maybe one of the largest meta-analyses. And the colleagues included 41 studies with 1,673 patients. And the average sperm concentration achieved after 1.5 years of treatment, of gonadotropin treatment, was 11.6. And this is similar to the data I showed you before from our data long ago, that on average you will not achieve normal semen concentration and other normal semen values during ejaculate analysis. And here is some important information on sperm concentration. And they looked how many patients achieved a sperm concentration higher than 0. So from azoospermia to some few detectable sperm. This was achieved in 78% of all patients treated, not in all, but a high percentage, but sperm concentration higher than 1 million per ml, only here in 55% of patients, higher than 5 million per ml, 36%, higher than 10 million, 24%, and higher than 20 million, 15%. So you can achieve, you can induce spermatogenesis, but in many patients you will not achieve normal levels. Unfortunately, these in this meta-analysis, no data could be included on pregnancy rate because not in all patients had a desire for fertility. So we have to rely here on sperm concentrations. And in this study also, the patient with congenital hypogonadotrophic hypogonadism had significantly lower mean sperm output compared with patients with hypopituitarism, similar what I have shown you before. And one other aspect which might be important comes from this study, and we have seen this, and I see this in my patients as well. If you once do this stimulation of spermatogenesis with gonadotrophins and repeat this later, this is much faster. And look at this survival analysis on proportion with detectable sperm. These are the values for those with no prior gonadotropin treatment compared to those who had prior gonadotropin treatment. And here, time in months. So if you once stimulate spermatogenesis with gonadotrophins and you do it a second time, this is much faster. So in some patients, I talk with them when they're 18 and they don't have a desire for fertility at that stage, that it might be useful to stimulate spermatogenesis once, and later, if they have a desire for fertility, a second treatment cycle will be much faster. And you can use this for your clinical practice. One of the last aspects I would like to talk about is that there is reversal of congenital hypogonadotrophic hypogonadism, and actually in 10 up to 15% of males, and this is a very recent publication from this year in the Journal of Clinical Endocrinology and Metabolism, in 10 to 15% of males with congenital hypogonadotrophic hypogonadism, there is reversal of this. And it always occurs following a period of normalized serum testosterone levels, because you have used gonadotropin treatment once, or GnRH treatment, or even testosterone treatment. And the testicular growth on testosterone replacement therapy is a hallmark sign for potential reversal of congenital hypogonadotrophic hypogonadism. And an olfactory phenotype, for example, Kalman syndrome with anosmia, does not distinguish between reversal or non-reversal cases. And this reversal can even occur in cases of severe GnRH deficiency. And this is very important to know. Even in cases of cryptorchidism, this can happen. But the reversal may not be lasting, and patients should have ongoing monitoring and be instructed to follow up if signs and symptoms of hypogonadism recur. So this is important during the long-term management of these patients. Before I come to the conclusions, I just would like to show you this slide, which I consider very important. And this is, again, very recent information. This comes from the guidelines of the European Association of Urology that have been published a few days ago. And they show here the reasons for a hypogonadotrophic hypogonadism. And they show you congenital or developmental disorders, acquired disorders, and systemic diseases. So some people might say what Hermann Beer is talking about, very, very few patients. I don't think so. I mean, these congenital forms are uncommon causes. But for example, hemochromatosis will cause hypogonadotrophic hypogonadism. And this is a common cause for this. And there are acquired disorders, different medications, drug-induced hypogonadotrophic hypogonadism, localized problems such as brain injury, pituitary neoplasms, pituitary tumors, and many other reasons, inflammatory infectious diseases, and especially the systemic diseases. Especially chronic systemic diseases can cause hypogonadotrophic hypogonadism. And in some patients, you cannot successfully treat this chronic systemic disease, and they have a hypogonadotrophic hypogonadism, where the only option might be gonadotropin treatment. So this is not very, very few patients. I believe hypogonadotrophic hypogonadism is quite often, and the gonadotropin treatment can be very successful. So what are my final management recommendations? Gonadotropin therapy is a rational and well-established treatment for male infertility resulting from hypogonadotrophic hypogonadism. The key task of andrologists, of you, is to use comprehensive diagnostic methods to identify the suitable patients for the gonadotropin therapy of male infertility. And please remember the last slide I showed you. Third point is pregnancies may occur even when the semen parameters remain within the subnormal range. And this is because normally the female partner has optimal reproductive function. Last point, and this is again quite important for your practice, gonadotropin therapy in these patients should not be discontinued prematurely. So I thank you very much for listening to my lecture, and I say bye-bye.